first part is you have to give a provisional diagnosis. A provisional diagnosis is something that I frequently use because a lesion is not a lesion until proven histopathologically, right? You can give whatever you want, it might turn out to be something else. Perfect. So, anybody can give the name of the classification. You can also jot it down somewhere if you want to do like that. Very good. Koos grading. Perfect. And the associated syndrome, NF2. Very good. So, see, now this is a spotter and can be a short case. So, if now spotter part is done, you have answered the questions and you will just move like Oschema, you will move to the next question. But I would like you to describe this. If somebody can come ahead and describe, so it will just add that cream to our discussion. You know? Anybody can come up and speak about the lesion. It's very simple. It's not at all complex.
Good evening, ma'am.
Hello, who is that?
Ma'am, Dr. Shubham Tyagi, ma'am.
Shubham is the constant speaker. Very well, Shubham. Uh, so your problems of consultancy have started now. You are
Yes, ma'am.
that's a usual thing. Perfect. So how would you describe it?
Ma'am, we are provided with ma'am T2 and ma'am post contrast images.
You look clear, more closely. Is it a post contrast
No,
image?
no, ma'am, it's a flare, ma'am. T2 and flare images.
Okay.
Ma'am, on the T2, I am able to appreciate a heterogeneously hyperintense, ma'am, well-defined lesion.
Okay.
Ma'am, centered in the left CP angle region.
Okay.
Ma'am, with intracanalicular extension. Ma'am, with intracanalicular part extending into internal auditory canal.
Okay.
And ma'am, the lesion is causing like a mass effect over the ma'am left CP angle with mass effect on the pons and ma'am cerebellum area,
Yeah.
which
Right.
will leading to the ma'am effacement of fourth ventricle, ma'am.
Okay. Very good. So moving on to the next one. So we have the
Ma'am, yes,
sequence.
ma'am. On the post contrast images, I am able to appreciate, ma'am, ma'am, nearly, heterogeneous enhancement, ma'am, nearly homogeneous few areas of hypo-intensity within, ma'am.
Okay. Very good. So your provisional diagnosis is, so based on the above said findings, the provisional diagnosis is a schwannoma.
Ma'am,
That's
vestibular schwannoma, ma'am.
so
With
the correct.
yes, ma'am.
So with intracranialicular component.
Extent, yes, ma'am.
Okay. And you have to mention the side also. So my
Yes,
provisional diagnosis is a left-sided
uh,
vestibular schwannoma. Yeah?
yes, ma'am.
So you described it very well. Yeah? Just to make it more clear for the rest of the people. So when you say it, na, so we have this is you have to mention the sequence first of all. So if somebody asks you for the description, then this is the description. You know? This is an axial T2-weight sequence. Perfect. Always mention the plane and the modality that has been provided. Make it a constant. So this is an axial T2-weight section which shows us that there is a heterogeneous T2 signal intensity lesion. The lesion has got two components. One, which is the intracanalicular component, and the other one is a more round to ovoid component. The lesion appears to be centered in the left extra-axial space, in the left cisternal space. The lesion is causing widening of the canal and is causing secondary compression over the brainstem, the pons, the peduncle, with resultant secondary alteration and compression of the fourth ventricle. Right? That's all what you're seeing over here. The flare sequence, this is an axial section of a flare sequence at the same level, which shows that there is some suppression of the signal on flare, whereas majority of the signal shows hyper intense component. When you move ahead, you get a contrast sequence. So if it's not provided, the examiner asks you, what would you like? You can say, I would like to assess the lesion with post contrast. So if the examiner then forward goes and provides you this sequence, then you can say, so this is an axial even weight sequence, axial even weight image, which shows that the entire lesion is enhancing, majorly enhancing lesion. However, with some of the non-enhancing areas, which might represent the cystic or the necrotic changes, and certain serpiginous areas, which might represent the intralesional vessels. All right. And then you will go ahead that based on the above said findings, my provisional diagnosis is a left-sided vestibular schwannoma. So then, uh, what are your differentials, Shubham? Are there
Ma'am,
any differentials?
ma'am, by looking at the lesion, ma'am, there is like no, ma'am, differential. But, ma'am, like we can consider meningioma, but ma'am, there is no differential, ma'am. If we are able to appreciate that intracanalicular extension as well as, ma'am, non-enhancing areas.
Okay. Okay. So you can say that no closed differential is available, or I cannot come to a closed differential for the given provided lesion. However, uh, the differentials possible are one meningioma, right? So how would you differentiate a meningioma over
Ma'am,
this lesion?
meningioma will have a ma'am dural tear on post contrast image as well as ma'am on ma'am like GRE sequence we are able to appreciate blooming also, ma'am, as well as ma'am that will be more centered, ma'am, like with a broad base toward the tentorium, ma'am, if it is a meningioma, and ma'am on post contrast it homogeneously enhances, and ma'am, if the CT is provided, ma'am, we can look for calcification and ma'am any ma'am bony remodeling overlying it. Ma'am.
Very good. So yes. So when if somebody is persistent, and you can say that if I'm persistent to you that I want a differential, then it is okay. You can say that a closed differential is not available given the characteristics, imaging characteristics of this lesion. This is like a very good standard line. You know, we can always use this line that based on the imaging characteristics, a closed differential is not available. However, given the location of the lesion, given the location, the other possible differential is the meningioma. The points against of it being a meningioma are, what are the points against? Again, what you have said, that the lesion, the meningiomas are more broad based to the tentorium of this petrous lining, right? So they will form an obtuse angle to this petrous bone. This is the petrous bone, right? So they are more broad based. They will form a more obtuse angle to the petrous bone. They are more homogeneously enhancing, and they, if a CT window or a bone window is provided, they might show associated hyperosteosis, whereas these schwannomas tend to cause osteolysis, right? They
Yes.
tend to cause widening, they tend to cause osteolysis. So my question to you is that do meningiomas can show intracanalicular extension?
Yes, ma'am. Ma'am, meningioma also can show ma'am intracanalicular.
Yes. So just having an intracanalicular extension is not a point against a meningioma. That if you see an intracanalicular component, something like this, then it cannot be a meningioma. It still can be a meningioma, but the other points have to be given consideration, right? And the other points were something that we have discussed.
Yes, ma'am.
So the most common tumors we know, 80% of them are schwannomas. And the classification's name is Koos classification. The associated syndrome is NF2. A lot of us, even when I was doing my residency, a lot of us believed that the schwannomas go like this. They start from here and they go like this. How many of you have believed this by far? Please tell clearly. I have believed it. So in entire of my first year, I would say in half of my second year, I thought that it goes like this. So I would always say that the lesion is here and it is showing some intracanalicular extension. Any of you have thought like this before? Or everybody of you have been smart? Okay, Ashok has been like me. Shobana says always. Anybody else? Oh my God. So many. of you belong to my family. So the thing is that because of its origin from the vestibular part, from the vestibular nerve, they have to originate from the canalicular component. They primarily originate from here. And that is what gets clarified when you see the Koos classification, and that is the value of it, right? So when you describe a lesion, do not say that it is showing intracanalicular extent. You say that the lesion is located over here and here. We do not know where did the lesion come from. When we say that it is showing an intracanalicular extent, then we say that maybe it originated from this part, from the cisternal aspect, and then it went inside. Okay, the better way to say is that we see a lesion which is located over here. It has got two components. One is intracanalicular component, and the other component is located over here. The schwannomas, based upon the grades, the grade 1 is the one which is located completely within the canal. That is the intracanalicular part. That is grade 1. When it starts peeping out, okay, when it starts forming the ice cream cone, the thing that we have all learned. So then it starts peeping out from here and tries looking into the cisternal space, but still has not contacted the brainstem. That is grade 2. The grade 3 is when it comes and touches the brainstem without causing its distortion. That is grade 3. And grade 4 is when it starts compressing the brainstem. So ours ones by classification is grade 4 schwannoma. Clear? So by definition, they have to be in the canal. And from the canal, it depends upon their wish where they're going to extend. So whether they're going to extend over here to the cisternal space, contract it or compress it. Yeah. Trumpet sign, ice cream cone sign, whichever you like it better. I like ice creams better, so I like to call it like that, right? Perfect. So which one do you think is what? So we have already seen schwannoma. The first picture, the first image, is it a schwannoma?
Ma'am, first one is ma'am meningioma, ma'am.
Okay. So does it shows an intracanalicular extension? Does it have an intracanalicular component?
Yes, ma'am. It is also, ma'am, having ma'am intracanalicular component, ma'am.
Perfect. But there is a difference in both of these enhancements, right? Look
Yes,
at it.
ma'am. Yes, ma'am.
Homogeneous.
Yes, ma'am. Homogeneous as well as it is enhancing more than ma'am schwannoma.
Yes. More avid, more
Mm.
homogeneous.
Yes,
Also
ma'am.
also depends upon the degree of the viewing that you do. But more homogeneous, more homogeneous, more avid. What about this one? A dural tail.
Ma'am,
This
dual tail is there.
to appreciate and
Yes,
look at its beak. Very
obstruct.
flat, right? It is very flat over here. Whereas when you see the shape of this, it is very convex over here, right? Another way of saying that its origin has got a broad base and its angle is more acute, its angle is more obtuse. But rather than going with the angles, I like to say it like it is more flat and it will always follow the petrous bone like this, whereas it will try to show the bulge along the petrous bone like this, right? And that is one way you can differentiate a meningioma from a schwannoma. Perfect. So anything abnormal over here?
Yes, ma'am. Ma'am, there
What?
is like T2. Ma'am, we are provided with axial sections and we are able to appreciate, ma'am, T2 hyperintense, ma'am, cystic lesion, ma'am,
Okay.
in the ma'am right CP angle, ma'am.
Okay.
And ma'am, it is like, what's it? Ma'am, it is like suppressing on flare sequence. It is, ma'am.
I will help you. This is the diffusion. This is the
Oh,
diffusion.
ma'am, it is not showing diffusion, ma'am. It could be a arachnoid system.
Okay. Very good. So what do you see? An axial T2 wave image with a lesion which shows very CSF-like signal, no?
Mm. Yes, ma'am.
Significantly, completely homogeneously bright on T2 wave
Yes,
image.
ma'am.
But it appears to be causing what? Why doesn't it looks like a CSF space? Because it is causing localized mass effect.
Yes, ma'am. Mass effect it is causing.
Yeah. So it is causing localized mass effect. That is why it appears to be relatively defined from the rest of
Mm.
the CSF spaces.
Mm.
And it does not show any diffusion restriction. So our diagnosis is uh, arachnoid cyst, right?
Arachnoid system.
What if I say that there is a lesion which shows diffusion restriction?
Then it is ma'am epidermoid system.
Perfect. So these are the four things, quite four common tumors that you come around, four common lesions rather, I would say, out of which two are tumors and two are cysts, right?
Yes, ma'am.
And if it restricts, then it is an epidermoid cyst. If it does not restrict, then it is an arachnoid cyst. The
Yes, ma'am.
management for them is, what is the management?
Ma'am, surgical, ma'am, resection.
Not always. For arachnoid cyst and for epidermoid cyst, surgical resection is not the primary modality of choice. They just wait and watch. If they are not causing anything, if they're asymptomatic, they try not to touch these lesions because they are enveloping the adjacent nervous structures, neural tissues, right?
Mm.
The nerves which are exiting through the brainstem. So any kind of surgical intervention is risky in them, so they try and avoid it. Even for the schwannomas and the meningiomas, they might not able to resect it completely, and still significant amount of the tissue might be left behind. So that's one thing that can help you in differentiating all these four lesions, something that we have discussed and we might just revisit. So most common is schwannoma. If somebody asks you most common CT angle lesion is a schwannoma. And this is the second most common. Meningiomas are the second most common lesions, right? As we said, IAC, the only one which is going to erode the IAC, widen the IAC is schwannoma. Meningiomas will show extension, but they will not cause widening. Also, meningiomas have a tendency to cause hyperosteosis, so therefore they do not widen the they do not widen the space. They maintain it. They just try to extend through it. The shape is ice cream cone, and also, as we said, trumpet. That is also correct. Ice cream cone appearance is also correct. They are broad based, just like we saw it right now, completely along the petrous bone, and they form an obtuse angle as compared to the schwannomas. T1, we know iso2 hypo, iso2 hypo, again T2 heterogeneous, iso2 hypo. So both will enhance. Schwannomas also enhance very well, but the enhancement is not homogeneous as compared to meningiomas, which are very homogeneously enhancing lesions. Restriction, no. I would not completely agree with the restriction part. For description, if you have to choose one, yes, but for clinical practice, they do show restriction depending upon the contents and depending upon the cellularity. So, some mild restriction of an ADC value of zero point 0.8 and zero point 0.9 is something that you can encounter in your clinical practice. But if you have to say that for an answer in the exams, no, they do not significantly restrict. Enhancement we have talked about. Calcification is rare in terms of schwannomas, but we know that meningiomas do calcify, right? And hyperosteosis, we know that meningiomas do. Restriction, which played a significant role, we have talked about it over here. And on T2, both are bright. Even the arachnoid is just more bright, completely simulating CSF, whereas the epidermoid is just bright, is hyper, might be not that hyper as like in arachnoid. So these are the differentials. So when we were talking about syndromes, this question comes in neurocutaneous syndromes also, right? It is just an overlap, might be shown some cases. And NF1 and NF2 are something which are being asked in and out of the exam. This is something or theoretical that you should know that chromosome 17, chromosome 22. I know you might be knowing 8, both are autosomal dominant. Age of presentations is also somewhere in childhood to early adolescence. That's also very similar. So, the CNS tumors is the part when you are shown up the cases and asked. So, schwannomas, meningiomas, and ependymomas. This is their spectrum. And the way I learn it is men with pen and two schwans. You might be having your own mnemonic, somebody having can put up a good mnemonic if they have, and that is what everybody can follow, but that's how I like it. Men with pen and two swans. Yes, miss me is something a very, very common one. Right? But this is something that I follow. In any of those scenarios, if you see bilateral vestibular schwannomas in your exam, just start looking for whether there is any meningioma or ependymoma. Okay? And this just does not hold true for your cranium, it is also for the spine. And they might be carrying and they might make it a big case, a long case when they will show you multiple modalities. They might show you a CT before, then they'll show you an MRI. Anything could be converted. Spotter, short case, long case. It just depends upon the kind of the discussion they want to have with you. Okay. So they will show you this. So when you see two schwannomas, go instantly and start looking for a meningioma. start looking for an ependymoma. And I have a lot of cases of that. I'll show you in the next one. I'm already telling you that one long case will be of this one. All right. So ependymomas in this stage true for the spine also. In the spine also, they have similar pattern of involvement. They might show you schwannomas of the brain and then ependymomas and meningiomas of the spine. All right. Whereas in NF1, they will show you optic pathway glioma, right? And then there might be astrocytomas and other gliomas, astrocytomas of the spine also, astrocytomas of the brain also, but then they will show you optic glioma. The moment you see an optic glioma, you should instantly ring that they might be wanting to ask you NF1 is somewhere around. Okay, so just start revising it in your head. Lesh nodules, and they have very clinical skin spectrum, as we say, neurocutaneous syndrome. So yes, you can freckling, tepiole, neurofibromas, lesh nodules are something. These words should instantly strike you when you see an NF1. Sphenoid dysplasias and multiple neurofibromas. Also, what might happen is they might show you multiple skin lesions like a neurofibroma, and then they might show you an optic nerve glioma, and you just combine both of them and go to NF1. All right. So this is the imaging part of it. That is men pen with two swans or miss me. Miss me is equally cool. So features is NF1, NF2, and so this is what we have discussed, right? Optic pathway glioma and then association, the differentials, vestibular schwannomas. I've already told you that sporadic unilateral is something which can also exist. Sometimes what happens is you just see a one schwannoma and one meningioma. That doesn't make it an NF2, right? But visualization of that should always raise a suspicion. Sometimes a schwannoma is in development, is an evolving from very small, you tend to miss it, and that just not might fit into the criteria. This is what we have discussed, multiple intracranial. So we are done with this part. We have already talked cutaneous neurofibromas. There is this plexiform segmental neurofibromas, entire huge limb. This is also one thing that comes up in exams. Entire huge limb is being affected by that plexiform pattern of neurofibroma. And we know about the target sign. We know what the enhancement pattern and what the target sign is. They might come up with that also. We know the spinal gun we have talked about that we might see schwannomas. Schwannomas might also be shown, ependymomas might also be shown, and meningiomas might also be shown.